Perfect. So as people slowly come in, I think we're ready to start this session with an exciting case and exciting technology to be discussed in the next 90 minutes. This is a tools and techniques session that is sponsored by Abbott Vascular, and it's OCT-guided PCI for a patient with calcified lesion, and the title says it all. I just put these three together. We're talking today about OCT, maybe about orbital, we'll see, and the drug-eluting stent, of course, that makes a difference. The learning objectives are stated as it's written here: to understand the value of actionable intracoronary imaging in patient treatment journey and how to adopt procedural strategy. An important point coming out of all these imaging studies that we had this year. To learn the utilization of orbital atherectomy, again, that's a maybe, because the patient has, I can tell you that has changed just on short notice. We'll see. And to know the impact of the DES platform, and that's part of our discussion and your questions and answers. This is the team. I'm Andres Baumer. I'm from London. I'm going to be the anchor. Hussam Noor doesn't need an introduction. He's the spokesperson. He will collect the questions that you type into your app or point out if you go up to the microphone to ask the questions. We've got the operator, Hussein Al-Amri, who will be coming live fairly soon. Naija Al-Nitaifi is the medical coordinator on site. And we've got the team here. That is Ahmad Al-Shati, Mohamed Balgit to come, Julia Mimli, and I can't still say it, Julio, after 20 years. Julia Limi and Ahmed Kashaba and Goran Stankovic, who is arriving there and who is the procedural analyst if we have something to draw. So this is what we do. A slightly different format today. We're going to start with the patient presentation and then go straight to the cath lab for the key objectives, and they will tell us what actually they have in mind for this patient with a live case, and of course that's from the Prince Sultan Cardiac Center in Riyadh in Saudi. The live case would be followed by an OCT in calcified lesions talk by Giulio, and then followed by another talk, how tools in the cath lab can help in approaching long calcified lesions from preparation to optimization. I've seen those talks and they are spectacular, really. We'll have a short discussion and audience interaction at the end, so collect your questions, really. It's important because they will be having a short time at the end of the session. With that said, I'll hand over to Hussam Noor for the patient presentation.
Good afternoon, everyone. It's my pleasure to be here again. And forgive me, this case has been back and forth, so we got to know the case just very late. So it's an OCT-guided PCI done by our friends and colleagues from Saudi Arabia, Prince Sultan Cardiac Center in Riyadh, by Dr. Hussein Al-Umari and Mohammed Al-Hulayfi. So 69-year-old male with history of hypertension and diabetes, symptomatic with angina. He has no symptoms of heart failure. An examination was unremarkable. From the labs, which is, I think, pretty pertinent when I looked into the case, is that his creatinine is 135 and his HbA1c is 9.7, which is not uncommon in the patient population that we see in this part of the world. But we're good with an LDL almost. So his echo revealed an ejection fraction of 55%, hyperkinesia on the inferior wall and inferior apical walls, and no significant valvular abnormalities. And he underwent a myocardial perfusion scan, which detected a large amount of ischemia in the inferior and the inferior apical area. So that's the baseline angiogram that was sent to us, and let me run it again. So the right coronary showed multiple lesions, long, smallish vessel. And as we will learn through this session, you can appreciate significant lesion in the LAD and maybe in the circumflex artery, but the LAD looks calcified, long, and involving, I believe, the large diagonal, which itself has disease as well. So it's pretty complex calcified lesion affecting multivessel. Different views. That diagonal should, I think, it's large and should not be ignored as well. So we should pay attention to that. And that's the spider or the caudal view. There's also ramus involvement. So in summary, this case is a 69 male, all risk factors, symptomatic with multivessel disease. And the most critical disease in this is the LAD, heavily calcified long lesion.
Quite a lot of work, I think, ahead, and it's probably now the time to go live to Riyadh and communicate with the operators and get their view on the strategy and what's to come in this live case. Hello, Riyadh. They're coming. Hello, Hussein.
Good morning, Hussam. Can you hear us?
Hello. We can see you, we can hear you. We just had the patient presentation, and now we're keen to learn from you what your procedure will be.
Thank you for the presentation, and thank you for inviting us. We already dilated his RCA, and we stented that with 2 stents. Can we show the final result, please? We did that just to support the lift system in case we need any debulking device. Show us the last slide. Last one, please. It was difficult. We had to use guide liner. We had to use multiple high-pressure balloon. Okay, go next, please. Next. Next. Can you see the screen?
We can see the moving images, lovely. So you've achieved a good result in the right, and now we're looking at a LAD with a diagonal wired.
Exactly. You know, our plan was to dilate both the LAD and the diagonal, and before that to do an OCT. However, the OCT did not cross. Even the smallest balloon could not cross through the tight lesion, the calcified nodule there, and after the diagonal. So we exchanged our soft wire with the rota wire, and our plan is to go directly and do the rota for the LAD. So what do you think? We could not cross even with a small balloon. This is the balloon, if you see.
Yes, we can see. So the stop point is immediately after the ostium of the diagonal, right?
Exactly. This is a macro catheter we exchanged for a rota wire.
So you use a stiffer wire?
Yeah. No, this is a rota wire.
Rota wire, so, not at all stiff.
Exactly.
Okay.
It's an extra support wire. Okay. So what do you think? What should we do now? Shall we go, you know, since the balloon does not cross? Our plan is to go and go with the rotaplator, then to do the OCT. Yeah.
I mean, there's not much else you can do once if you get a wire across, but nothing else, then that's the hour of the rotablator, right, Mohammed?
Hello, Hussein. How are you? Mohammed Belghith. I think the microphone, yeah. This is Mohammed Belghith, Hussein. I think we agree with you here as panelists. I mean, you stuck already. You could not, you know, cross with the smallest balloon in the cath lab you have. I don't want to disagree with you. This is what we do on the real life, and this is your decision. You are facing the case, and I think if you will start with rotablation, which burr you going to use? 1.25 or what?
Yeah, we'll start with the smallest. If we need, we can upgrade that. So we'll start with 1.25. We are going now with the dyna to come close to the left main. We are approaching, hopefully.
So you're already starting, but the strategy, I take it, is debulking, then OCT, and then further preparation of the lesion and preservation of the side branch. Is that the appropriate summary?
Yes, exactly. We already took the wire out of the diagonal. After the rota, we can reinsert the wire again.
Okay.
We'll go to the proximal LED, then we'll start the... Okay, all right, that's fine. Okay, let's start the rota, please.
Mm-hmm. So you haven't showed us the rotablator steps, but I assume you flushed and you park in the left main. And this is a small burr, which is probably just there to create a channel in the first place. 1.25 millimeters.
We'll go multiple sessions until we can cross.
Giulio.
Okay, it became extremely clear from this AP cranial projection that the calcification is going in two directions, also involving the ostium and the proximal part of the branch. So, and that is a very important diagonal feeding the vast majority of the anterolateral wall. Mm-hmm. So now we needed to get into some more details about how to deal with this bifurcation. This calcify a little bit longer, is not very short. Goran, I think, is the best person. Yeah.
I somehow anticipated this problem in crossing. If you look this cartoon that I prepared, they are still working. I need to wait for them.
Can we get the whiteboard up?
No, go ahead. You know, we already finished the rota.
So we know that plaque is in the lateral wall opposite to carina. And you see the tightest point here is exactly at the bifurcation level, exactly where balloon stopped. I don't know if you can see it here.
Can we get the whiteboard up, the smart screen?
So balloon stopped here exactly where is the plaque in the lateral wall really encroaching deep inside and compromises passage of the balloon. And I fully agree that throughout the length of the LAD up to distal part, and there is more diffuse disease distally, there is huge amount of calcified plaque and also in the ostium and proximal part of the diagonal. Because of diffuseness of disease, after lesion preparation and selection of strategy, it's more selection of devices based on OCT than the strategy. With such diffuse disease in both, I believe the safest way is to do two-stent strategy up front because it's the only diagonal, as Giulio said, supplying the whole lateral and part of the anterior wall. So my strategy would be to debulk, do OCT, do NC balloon predilatation, and then focus on bifurcation.
Thank you. I think you heard that, Hussein, and I think that aligns with your strategy. And
exactly, yeah.
We're keen to see the next steps.
We already did the rota, and we'll do an angio now. We'll just exchange the wire to a more friendly wire than the rota. We'll recross with the to the diagonal, and then we'll go ahead and start the dilatation.
So you're confident that you can dilate now? Did you test that, or?
Yes, hopefully we can.
Mm. And you're taking a microcatheter in to exchange the rota wire for a standard wire and then rewire the diagonal, and then you've got proper guide wires in both vessels. Okay. Whilst we're watching you, Julia, what do we get out of the OCT?
Well, first of all, it's a little bit challenging because the guiding catheter is not fully oriented and is losing a little bit of contrast inside the aortic roof. So it should be crucial to place and to seat the guiding catheter at the time when he is planning to do OCT in the proper way to get the maximum contrast and clarify. Here is the value of the imaging, because we are seeing incredible calcification, but we would like to get a little bit more about the type of calcification. Probably is a concentric because the balloon was stuck, but we wanted to understand also the thickness, and if we can go with a cut-in balloon or if we needed to escalate in the burr. And we are going to take measurements about the effectiveness of this very small burr, because we do not expect it to have a very big lumen, and we needed to plan the strategy.
So basically the size, the length, that's the usual, but also the choice of the next tools, devices. Excellent.
I have a question for Goran, actually.
Yes.
Would you in any case dilate the side branch before rota, the main vessel, beforehand? Like dilate the diagonal actually before, like try with the balloon.
No. They had problem at the level of the entry point at the bifurcation site, so it was not expected that you can go inside. LAD is the key. It's the anterior wall and the most important one. So when we treat bifurcation, we do most of the work focusing on the main vessel, and of course this diagonal needs to be preserved. But with the rota, at least according to all the available evidence, the risk of compromising ostium is extremely low. So performing rota is safe.
You know, I think dilating the side branch first carries a risk of dissection to that side branch and complicating the procedure before even we start. So the best is to leave the side branch to the end.
Goran, while Hussein is working there and going with the calcium that Joel, you alluded to as well, which is heavily calcified osteal and the massive big diagonal as well. Do you, do any of the panelists or anybody would do at this moment imaging, because do you want to modify the plaque before you do a two-stent strategy?
Dilate with a small balloon so that we
whilst
can...
you work then and they don't expand and then you regret.
Yeah, I agree with Giulio completely that decision regarding possible upsizing the burr size can be based on the imaging at this point. And regarding the diagonal, I agree with the team that we should focus first on the LAD and then just leave wire in diagonal, which gives us safety accessing if necessary. But I will not open two territories before I decide the pre-dilatation strategy and stenting of the main vessel, and then focus on diagonal.
Perfect. Okay. So again, for the audience, you know, use the app to give us comments or questions. There's always time in between the main steps of the procedure when they work, and we let them work in pace.
It's not very small.
That's nicely come up.
What is the size of the balloon, Hussein?
This is 2.5 by 30, and we'll go further down to dilate so that we can do the OCT freely. Okay, thank you.
Nice.
So with a smaller balloon.
So Julia, where would you expect that calcium to sit?
Yes. Sitting.
It's, you know, it's along the length, but it might also, some people might say it's all on the outside.
I think that before injecting, you can see that is going also in the external part of the vessel. Seems that you have beside the vessel. So the calcium is not only toward the lumen, but we mentioned many times that this morning is going also toward the external part of the vessel. Mm-hmm. So of course we are focused on the lumen. We need to understand a little bit better.
Okay, we'll go with the OCT, if you agree, since we have a good lumen now. Probably the OCT will go easily, and we can assess.
So you're saying you're preparing the OCT now?
Yes, we are going with the OCT now.
And just for everybody, you can see the injection in the angio and the amount of contrast that is going to be lost in the aortic roof. So at this point, it's very important not to push, but to handle the catheter and try to sit a little bit more properly to get the best imaging possible, because we wanted to get only one pullback. You remember is 55 of EGRF in 135, so we needed to minimize also the contrast in this case.
Julio, at this point,
actually,
we
this
focus
engagement
on
is only
morphology, length of disease, diameters.
And where to land eventually. So the tiny point is at the tip of the catheter that is advancing, perfect. No, okay, good. A little bit behind could be better, so we can see also the proximal part. If you're pulling back a little bit the catheter, just a few millimeters. Okay, I think it's perfect as a position. And you tested before with the engagement of the guiding about the quality of imaging. Very important to have the wire inside because it can orient us.
All right, we are ready.
So now we're seeing the
Can increase the
live OCT.
If I may ask Julio about what's your take
can we
on
see the
the
screen?
contrast alternatives for the OCT?
It's a big vessel, it's a long vessel, one shot should be clear. So if you start mixing saline now, it's not going to be good. Because, so you can do on the right a small vessel, but now we need to get the proper imaging.
We now get a live view of the OCT console, it seems. We see your selection, pre-PCI, LAD, mid, and
75 millimeter, the
75
longest we
pullback.
can. Catheter is okay. They are calibrating. You can see this calibration, and they are ready. Okay.
Sorry?
And check the path, the quality. There is a little bit of contamination. It's very important to sit the catheter better. Okay.
that looks good.
Test from the
Calibrating.
okay. Sitting.
And this is now
Perfect.
automated
See a lot
pullback.
of damage already is coming.
But that's the mechanism, so we are expecting that. It's
Okay, balloons plus
Yeah.
rotational. Perhaps we will be able to identify the different segment where the balloon was acting with the rotablator said accept. You can see, so this is Ultron, so you have a different type of orientation. On the left side, you have a P, stay for proximal, and here you can see big crack of the calcium dissection. So now you can move. Number one, the calcium is identified by orange and is automatically detected. If you can go to angio co-registration, if you have angio co-registration, and if you can show.
Shall we see one? Shall we see? My
we don't
proposal
have
would be: shall we see the pullback once, just running through, so that we
save
can
this one.
get an idea, and then we go through the analysis.
You can see the pullback. Can we shift the screen to
Yeah,
the
like
pullback?
so. Can we get that on the screen? Yeah, that's good.
Okay,
Can
anyway.
we see the angio?
Okay, here.
Yeah, shift to angio, please.
Okay, here you can see in orange
Yes.
the arc of the circumference where the calcium was. You can see big crack if you are moving, and you have the angle of the calcification that was supposed to be very wide, and also the thickness that is identified. So if you have the angio co-registration, perhaps is okay. Otherwise, we are skipping
don't
and we
have
are
that.
going to get the visualization of the calcium inside.
We don't have co-registration.
Okay, go back to the morphology and
So we're listening to your analysis over there as well, and you tell us what the next steps are and what you are utilizing the OCT run for. at this present stage?
Let's first start with the distal landing zone. Where is the best landing zone, and
at the moment we see the
angio.
angio.
Okay, show the OCT, please. Can you shift? Yes, you can see it now?
Yes, thank you.
Okay. Bandar, go to the distal landing zone.
So very important to show that we have this tiny line, the white one. So inside you have the fully black is the lumen, automatically detect. Then from the proximal to the distal. And where you can see the tiny line, it means the EEL that is measured. Proximally, you can see that is 372, and distally is going to say that the EL is 283. So it means that you can go possibly with a 275, and perhaps we needed to see a little bit more the cracking of the calcium if you can move the cursor, because people wanted to see here, you can see bigger dissection plane at 1 o'clock, 6 o'clock in the middle. If you can go morphology, it's going to be more clear if you click on the top, so the people can understand much better the damage done by balloon. And if you are moving, perfect. And you are scrolling, you can see the crack at 1 o'clock, okay, very big, deeply into the calcium. You can see that the calcium is almost around 185 degrees in this case, is moving. You can see a dissection plane at 4. You can move in, scrolling a little bit, so the people. And the very important point is the bifurcation. The bifurcation is identified by this white dot, and you have the second wire. Can you see the wire? At 9, you have the wire going into the diagonal, while at noon, you have the wire going into the wire of the main vessel. If you are moving just a few frames, you can see the origin of the diagonal. Now the diagonal is coming at 9. And before, that is the segment before we crack. So it seems that there was a lot of work already done. And if you can go proximally.
Give me 2x30 balloon, regular.
You can see a lot of damage at all. And this is some plaque that we have before in the proximal part. Here you can see that the calcium is almost encircling the vessel.
But it's cracked.
And it's cracked. Before the yellow, before the orange, there is still some significant plaque. We needed to understand where to land. Can you see that still there is clearly calcification, identified by the line, the orange line. And if you can go back again, scrolling a little bit back toward the proximal part, still calcification at 8. Now there is not so much calcification, but there is still some significant plaque. And so let's try to understand where to land, going back more proximally. So this is calcium, not too back, because here we are approaching the left main, and the white point is telling you where the circuit is taking the origin. This is the post-ostium of the LAD, is calcified, but is a safe possible landing zone. Now you need to go to the size and take the measurements and then finish the preparation eventually.
Okay, so now we got it from the expert. Super analysis. What are your plans and next steps? You're gonna go and dilate the diagonal?
Stent the LAD, and then we'll see. And
Which
the
is
diagonal
tight?
is not easy to dilate. This is a 2x30 balloon. Maybe we'll take a smaller.
But it's one
shorter
that was already inflated and it's very long with the wings. Maybe that also contributes to difficulty in crossing.
Exactly. Give me one more.
Shorter balloon may cross.
Shorter balloon.
Okay.
Julia, while they're changing the balloons, I mean, there's fantastic analysis. What was pulling back the OCT? I mean, when we talk about the calcium, do you think it was a concentric calcium? Was it nodular calcium? Was it eccentric calcium? Was it a mixed variety of all of the above that we had?
Okay, that is a crucial point. The people are talking about nodular. Many times you have all these types of calcium combined. And so it's not just one entity, but you can have a protruding, calcification very smooth, then in another point you might have erupted, then you have a plate of a calcium. So the concept is this is a severe calcification and might have all these different types. Mainly was a concentric. That was the reason why nothing was crossing, and they took the decision after being stuck with the balloon to go back and take the rotational atherectomy for open up the lumen, and then they went with a normal balloon, and you saw the amount of damage, despite the fact that it was concentric.
Thank you.
Just one quick question to Julio. With
So
the
struggling there. Hussam, any role
me the
for
trial again.
orbital atherectomy? I'll come in a second.
115?
When it's so tight and so unpredictable, so small.
I mean, in my own limited experience with orbital atherectomy, when I see nothing passes with that critical stenosis, I think I will do what Hussein has done. I'll go to the rotation atherectomy, especially long calcified lesion like this one.
Okay.
Looking at the OCT imaging and all the cracking or fractures of the calcium that we saw, you're expecting this was as a result of the barotrauma from the balloon or from the rotational atherectomy?
No, rotational is going to just gently smooth, and it was a 1.25 burr. So you can imagine, it's just smoothing the lumen, it's making small. That is the effect of the additional balloon. And we can figure out when we are just dictating the rules for calcium, which type of device to use based upon the calcium, that in fact, they use a simple 2.5 balloon. And they made a lot of crack. We are still learning about the connection between type of calcium and how to prepare the lesion.
But we always knew that if we use balloon angioplasty in tight lesions, it's going to crack the whole surface. It has to, otherwise it doesn't work, really. My question to you, Giulio, is out of the OCT, would you deduct that there is a role for further ablation, for further rotablation, or now maybe something else that creates a larger lumen?
So the most important was to go back and see that this type of cracks and fracture were done systematically along the way. And in fact, the balloon was fully open. So watch to the balloon is very important after the preparation. So I don't think we needed too much in addition. Now we are trying to get...
With anchoring, he's able to cross.
So we can see you're now in the LAD and you're pre-dilating further.
He was anchoring.
And there we go.
He was anchoring in order to cross.
There's a
with
balloon in the diagonal. So the whole proximal part of the diagonal is now pre-dilated and the balloon has nicely come up.
Seni, go. Inject. Inject.
And
Can you check the system, please?
actually, for a moment, I didn't look,
So
but
we
they'll
anchored
use
with
the
balloon
LAD
there.
balloon as an anchor. I
As
guess.
an anchor, and then they crossed.
Julie, I have a question. For the proximal LAD, it's a very elliptical artery. Like the artery was like almost elliptoid. What's the sizing before the alteron coming in? What's the EL would be?
That is the point. So OCT is no morphology. OCT is morphology plus measurements. And so now when they will finish, we can go back and move to the automatic measurements to understand. We fix that the distal part is at least 280, so perhaps 275 stents, then is very long, and then we need to take the measurements approximately.
Seni, go.
Okay, tell us where you are and
We have a
what
good
the
result.
next steps will be. This looks already
We have a good
very
result
promising.
in the diagonal. The ostium is well open. I think it will be very complex if I go up front with 2 stents. I will go with provisional, and if we need, as we can always deploy a second stent if the result is suboptimal. Okay, give me the stent, please. We'll go first with 275 by 38 stent distally.
And it should
then
be
we'll
nicer
take
to go
3 or
back and
3.5.
measure also the length from OCT, because that is crucial. And
Yes. What is
because it seems to be very long segment.
30? Distal 30? That's after the diagonal, I will land.
So
By OCT, it's 275 by 30.
275/30, yes?
I'm sure.
Okay, that's not
Yes.
going to cover all of it, but then it's the question
that's-
where you
that's
plan
the
to have
first
the
part.
overlap. Oh la la.
And also because the longer is the stance, the more we are going to get in trouble in crossing the first part.
Give
Well,
me the
you're picking up
guideline,
friction
please,
right,
again.
on the way, so the longer the stent, the more friction.
Or, give me another anchor. Let's
Will they
hold
deal
all the
with
way
it?
up.
I think anyway, Goran, should be very important to avoid
no,
to
2 by
get
10,
the
no,
overlap
2
at the
by
level
10,
of the
or 2,
bifurcation.
2.
No, no, absolutely not at the level,
Right.
either proximal or distal, but not at the level. There is already plenty of plaque, calcified plaque, so it's better to avoid that part.
Do you? I don't know how you do it, but usually what we do is we take the longest that we have for the distal part, appropriate to the distal size. We implant that, and then we see what length is left, rather than have 2 stents open according to OCT. I'm still not too confident about that. I don't know what you're doing, Julia. You probably plan everything.
Well, that is the reason why we are using, just to get the right measurements done. So is something that is very relevant for selecting the proper way.
And equally important, I think, as we're discussing in the morning, is to select the landing zone exactly from the distal landing zone, and
Correct.
this will also dictate the length.
And that is critical to get the co-registration. Angio co-registration, when you fix, is projecting exactly in your angio where to land distally and proximally.
Let's listen to.
They're trying to balloon.
I mean, we watch you work, and I assume what you do is you put another anchor balloon in.
Yeah, okay, no. I think we'll take a guideline, or even with anchoring. I cannot move the stent.
Yeah. And now
Yeah,
you're changing
guideliner.
for a guideliner?
Yeah.
Which is not trivial if you have 2 wires down, right?
We'll take the diagonal wire out.
Yeah, most of the time when you put the
Or we
guideline,
can
especially
optimize
fixed
with
branch,
the
you feel
3
a lot of
balloon.
friction if you have 2 wires, and many times we remove.
Give me a
one of the
high
wires,
pressure balloon,
especially
please,
the
3.
branch wire. But I think he's
Give me 3
secured
by
the osteo
30.
diagonal now with few ballooning.
It's a tricky angle with plus calcification. So I mean, we know it would be a challenging case, and I think you're making excellent progress there. Whilst you're working, we let you get
We'll
on
balloon
with it.
again with a larger balloon. We'll take a 3 by 30 and see if we can cross.
Okay.
If not, we'll take a guideline.
There's still a lot of work. We haven't talked about the distality, because there is still a lot, going on until up to the apex, where we normally wouldn't want stents. What would be your strategy there for the distal part of the vessel, where there is further disease in an area where, at home where I work, the surgeons always say, do not put stents there because we might come into this region.
Well, if you mean the very apical LED, it's quite very small. I think in my eye at least it's less than 2 millimeters. So I will avoid doing anything in there. But maybe after opening that proximal LED and now more flow is distally after nitro, it's a bigger artery. I will do DEP if OCT is allowing it.
Okay. So the argument would be it's too small to warrant a stent, but maybe a drug-eluting balloon, just to preserve the flow. We know flow is important for the patency of the proximal stents as well. So I'd be concerned. And
The distal part of the LED didn't seem to be so involved by plaques.
we'll see what what happens when the proximal bit
Andreas,
is...
No, the inflated
what I
balloon
would-
goes easily, so
Coming back
probably
to the same
should
concern, I mean, I would.
What was the
areas
size of the balloon,
significance
Hussein?
And then reassess that later.
That's 3 by
Not uncommonly, once you open
3
up the distal downflow, you give some nitrous, they may actually
Hold the other
become
way.
bigger.
It's this one.
So I won't go preemptive
what you
with
think
this
you do.
LAD.
Yeah.
The other, it's a very challenging case.
The other
The
way.
other thing that would do when I have heavily calcified
way.
vessel
This one.
bifurcation,
It's coming out.
I've been shying away from 6 French guiding system. I have radials, I go 7
Straight,
French.
straight with 7.
Straight
yes.
7.
Straight with the big guns
Yeah.
and to have maximum backup. Okay.
The only problem in our area is the radial artery is small, and a lot of the ladies and men, when we have a lot of
But if you take
Yeah.
Give me that.
slender,
yeah, we use it. We use
Slant.
both. But I think if you have this plan, maybe you go femoral and make your life easy. It's gonna be one case every month like this.
Okay.
All these
Yeah, I think it's always a, it's give and take. But with the femoral, you have a slightly higher bleeding risk, but might have a much improved backup from the radial. You can go up to 7 French with the glides, with this slender
Or sheathless.
or sheathless.
Yeah.
Yeah. But of course, it's always easy to talk about options when you're not standing there and trying to get the stent in the LAD. Well done, see?
Nice.
Excellent.
oh, bravo, bravo.
Or
In
back.
cases of
Let's see, what do you think of the
Back.
landing?
So we weren't taking.
Back or it's-
So what did you do differently now?
He pre-dilated
We
with
just
3-0.
dilated with a 3 by 30.
He took 3-0 balloon.
So further
High pressure
pre-dilatation
Yes.
made way for the
Exactly.
stent that it finally went in. What are your considerations for placement and avoiding overlap of the at the diagonal?
Yeah, now he's distal already.
Yeah, I'm trying. Yes, now we are distal. We'll just go nominal. Go.
In cases of absence of co-registration, as this case, sometimes I use the marker of the branch as a marker in the OCT, the dot of the branch, determine the distal landing zone and calculate the length, and go just 1 millimeter distal to the branch, and then we can assess the length accurately, and then overlap the proximal one.
And especially now with the new software coming that is Ultron 2.0, you have this incredible enhancement of the view when you are placing the stent, because side by side you might have the angio co-registration and you can see where you are placing the stent. It's really likewise to get a much more signal from the angio, and you can be more accurate.
The guide is seated.
Okay, so now you've deployed a 2.75 by 30 millimeter stent, and you've removed the diagonal wire.
Yes.
We're getting there.
We'll take a 3.5 now by 23. What do you think?
This is long.
Well, I think that you can go back because you got the images and take the right measurements from immediately after the bifurcation
before the
to the proximal landing zone.
The wires.
Yeah.
Sorry? Okay, no, we'll take a 3.5. Give me a 3.5 by 23 stent, please.
Guys, I still think there is something going on distally. I mean, this is a wraparound.
الحمد لله
LAD,
فتحنا
right?
الشريان الثاني
It's not normal.
وتحملنا طعمه.
So what is your choice?
لا لا الله يجزاك خير. We took a Zen stent 3.5 by 23 because I believe the proximal LED should not be smaller than 3.5, and by the OCT it was 3.38.
And you implant that with an overlap just distal to the ostium of the diagonal, correct?
Exactly, with just a minimal overlap, we'll try. We'll bot and then we'll assess the diagonal again.
Okay, nice.
Test. Come caudal, please.
Change the view to
Okay.
RAO code.
RAO code only is coming.
Test.
And remember, perhaps you can go back a little bit and then recheck in the other view, because it was immediately after the ostial part
RAO
that you
code.
needed to land. Good.
That's good.
That's perfect.
Test. Okay. Everybody happy? What do you think?
Yes, you have a good overlap, right,
Go ahead.
between the two?
Yeah,
Got a
there's a good one.
nice overlap, nice proximal landing.
About 12, 14.
How many atmospheres?
14. Since we are already oversized, if it was a 3, we'll go higher, but we'll take a high pressure balloon now. Give me 3.5 by 15 balloon, please. We'll bot and see the diagonal.
So you're now post-dilating without further imaging.
Yeah.
You just put an NC balloon through.
Exactly. Just
Can we go
some nice-
AP cranial and see the diagonal?
Sure.
And
Go
you have a
cranial.
jailed wire. That's a question that frequently comes up in these complex scenarios. You have a jailed wire now. Would you remove and rewire before post-dilation, or do you say actually they never get trapped?
And does that change with whatever wire you're using in the jailed wire as well?
They do.
Exactly. Hussein, you're post-dilating with high pressure. Ah, right. Okay, that answers the question.
It was difficult to come out, so
Yeah.
okay, let's bot and then we'll see what to do with it. You know, I took it out only because of the heavy calcium. It was difficult to come out, so I thought probably it's better to take it out before.
It's wide open, yeah.
Yeah, go ahead.
So now you're doing the equivalent of a pot just
Go ahead. 12, 14, 16,
before rewiring.
down.
The question really is,
Give me a new wire, please.
does he need to rewire? Does the diagonal need any further treatment?
No, but after pre-dilatation, result is much better, and it's really, for me, impressive how these vessels react on balloon dilatation only. With 2.5, you have unexpected cracks that you see on OCT, and look now, inflation in diagonal almost removed
with
the
OCT
lesion from
again.
diagonal. So
Now the distal artery looks bigger, so maybe you want to do something about it.
But I see your point, Andreas, talking about the cell.
Thanks.
OCT. Okay, we'll go back with the
Oh, the
OCT
pain,
to
I see,
see,
yeah.
to assess
Yeah,
the
yeah,
result.
So one
Then we
question
can deal
about
with
the distant
LED
stent.
afterwards.
So one question about the distant stent. It was not a post-deal with the non-compliant. Why not to do if you intended to do now and then check with the OCT the optimization?
Okay, give me a high pressure balloon, 3 by 30.
Hussein, just do as you think and let us know your next steps so that we can follow.
Yeah, we'll both dilate the distal stent, and then we'll do the OCT. Afterwards, I may assess the diagonal with an IFR or FFR and go accordingly.
Excellent.
You know, it's better to keep it simple.
Post-dilate.
This is a very complex lesion, and it will be a very long stent in the diagonal. And it's not going to be easy to cross, to be honest. We'll dilate the distal stent now, and then we'll do the OCT again.
Okay, size of this balloon is
This is 3 by 30 balloon,
3 by.
and we'll go
Long.
short of the edge. Down.
NC balloon in a 275 stent. You probably do the overlap as well.
Go 16, 18. Okay, thank you. Okay, let's go with the OCT now. Now we'll go with the OCT.
Okay, so next step is OCT assessment, I think. And then physiology for the diagonal. Is that something
Exactly.
you commonly do, gentlemen? Physiology for to see the significance of a diagonal pinch?
Now, when you remove the plaque from the main vessel, you have reliable measurements. So it's a valid option to exactly assess functional significance of the diagonal. But if there is a lesion which is less than 50% in dilated vessel, you may also consider leaving like that without...
Because of the tandem effect
yes.
of the, yeah. Okay, we can see the OCT probe going back in.
Sitting. Sitting.
No.
Yes.
Beautiful. This just about covers the stent length.
It's very important to get the lens that is the first intense marker outside the stent. If you switch on, you can see if you are inside the stent or outside the stent, because we needed to be sure that we haven't dissected the vessel. So I think, okay, here you can see that you are still inside the stent. Can you see the start? Now you are outside the stent. So you needed to advance a couple of millimeters more to be sure that there is no dissection. Here you are at the border, depending upon the flow. So you needed to advance 1 or 2 millimeters because we wanted to see, okay, now this, okay.
Not quite, huh?
This is the maximum we can go because of the distal lesion.
So, Giulio, in this case, you would say, I'd rather go in a bit and lose the proximal and do 2?
2 millimeters should be okay. When you are stop seeing the struts, means that you are outside. Okay, we are at the limit, but I don't want to make too much complex the things.
Anyway,
but the first to be checked is the outside part.
There's a comment from the floor.
I think the problem here is pushing the catheter, because you were talking about the distal disease, and the tip of the catheter cannot cross because there is a disease distally, and the distal LAD. And second problem that we may face as well is that opacifying the vessels, because you're going to block the distal tip of the LAD. So the dye going down is going to be...
So I think that was one of my observations. That's why I brought it up. There is no flow because the distal part of the catheter obliterates the LAD, which is quite tight in the distal part, right? But now we get beautiful pictures anyway.
So you can see that there is the flow distally, clearly. So,
diagonal is still there.
Okay. We miss the exit.
Okay, so diagonal is good, exit is missed.
There is a little bit of a significant contamination. So proximal part, let's just start from the proximal part. Here you can go inside the ostium. You can see a minimal dissection, but the landing was okay. You can see also the area, the numbers that you have below is the lumen area, that is 6 something, then 5 is advancing. Here you have seen the diagonal branch. Is the first marker, the first white marker is the diagonal. You needed to go back a little bit with the cursor. At this point you can see, so if you are moving back and forth, you can see the diagonal branch.
Okay,
this is the diagonal branch that is coming at 8.
8 o'clock.
okay, is, well, the area is 835, so seems to be okay. And then all the strata are well opposed. The yellow sign is to be controlled later on. So at this point was fully open with the area that are more than 4.5. Now distally, at the point of the other point, there is still some reduction of the area. So we needed to do some more work at the level of this white dot. This is the final, so the final part, it was not fully dilated. And on this part, we needed to get a little bit of more dilation.
Okay, Joe, let's hear from the operators. What are the plans? What is your interpretation of particularly the distal part of the stent?
You know, I always have a question in mind. Do we really have to make the stent circular, or we, just fix the stent to the vessel itself? We adapt it to the vessel wall and the vessel morphology, rather than trying to get a circular stent. Sometimes we already dilated with the 3x30 high pressure balloon. We went up to 18, so probably further dilating that, we could get a worse result, and the enemy of good is better. So I believe I'm happy with the result. Maybe that segment where we have stent not under expansion, but it's not well opposed to the wall, we will go for that, which is probably just after the diagonal. But distally, I will not dilate more because I'm afraid to have a perforation. Let's go with the IFR. I don't know, let's hear from the audience.
Okay, another point is that distally,
with a 3.
so at this point you have a blood contamination that is making the calculation perhaps wrong. So you can see the blood inside, and then you needed to adjust to have the right measurements of the lumen.
Mm-hmm. So I think you're making really good points to make the best out of the images, and not everything is fully automated, particularly if there is blood. But we're watching you, and we understand you're happy with the result as it stands. And if I recall correctly, you want to test the diagonal with a physiological wire, right? Is that correct?
عندك بول ولا وش فيه؟ He has a condom catheter.
And we still have the OCT image on the screen. Thank you. What wire is this?
This is the IFR wire.
IFR wire.
This will normalize first.
Okay.
Okay.
And you want to rewire the diagonal in order to obtain, physiological measurement to see, to guide your further steps.
Yes. Call the anesthesia. Let them help you. Done? Okay. I hope we can cross.
Yeah, it might be. I mean, these wires, whilst they have made fantastic progress, but they're just not your standard guide wire, right? So it's a bit more difficult to handle.
So that's brings us for Goran. Like, what's your tips and tricks if you want to do FFR for a side branch after doing bifurcation for FFR? Like, they are quite difficult to manipulate. So what you would do to get it?
As Andreas said, newer generation wires are more steerable and you can control more, but it's still far away from workhorse wires. So in our studies, stenosis less than 90% and TIMI flow 3 is the indication not to proceed with kissing and opening. If patient is stable, if ECG is without changes, and we have TIMI 3 with residual stenosis less than 90%, that's in contemporary studies indication to stop at that point. If you want to rewire, then you rewire, use microcatheter and exchange for IFR.
But you have
So
eyes, so how do you
let me just be
normalize?
cheeky and ask the audience here. Based on this angiographic image that we have, who would be happy with the situation in the diagonal and just stop at this stage?
Wow.
Who would dilate the diagonal just to be sure? And who would do the IFR, FFR if you can?
I will not do it.
Okay. So we're very interested. The outcome, if you have that, the majority here in the room actually thinks you've already done a fantastic job. And the fact that there is TIMI3 flow, no ischemia, no pain, and only a moderate nick there at the ostium of that diagonal, if any, most of us would leave that alone now.
Actually, I'm very happy with this decision. It makes my life easier.
Maybe use the IFR for the distal LED.
Correct. Why not? It's open.
Then,
It's
you know,
already paying.
if that's positive, then we'll be stuck.
There's a question from the floor.
Hi, I just have a question on the reliability of FFR in such cases, assessing the side branch during bifurcation PCI, because we know the FFR on a stable plaque, which is unlikely to progress over the next month or two, is reliable, whereas this is a dynamic plaque. There are some spasms of what could appear as 70% could be 50% in 1 month's time, or the other way around if there is neointimal proliferation and so on. So the FFR that you're doing now may be different in 2 weeks' time. So how reliable is it? I mean, how much data we have to support this?
Yeah, we have data from Korean registry, large number of patients. The data is reliable, and based on post-crossover FFR evaluation of the side branch, you can defer further intervention with 5-year outcome that is good. So after crossover stent, you cannot do it before because plaque in the main vessel interferes and influences measurements. But after crossover and optimization of the LAD, you have very reliable data in the side branch, and based on FFR, you can defer further intervention.
I think there's also a series from ALTS. But,
Yeah, but this one is 5-year clinical outcome, so you speak about a long-term clinical outcome.
Yeah. We are talking about the diagonal here with Julio, and I think all of us here, we agree the flow in the diagonal is nice, all the branches maintained. I don't see a point to...
I think, we've done BBC 1, if you recall, and there was, if you were in the provisional, it was clear a case like that we would have to leave alone because it was TIMI3 flow, no dissection, no pain, no ischemia.
The OCT.
And the outcomes were better.
And there is even a randomized German study, Tibius, based on TIMI flow 0 as the only indication to intervene. Otherwise, leave it alone, no difference in clinical outcome.
Okay, Hussein, we're having discussions here, but we're not ignoring you. We're just seeing what you're doing, and please let us know where you're at.
Actually, I really listened to you. I think it's a good idea to leave it alone. We'll make it more complex and probably will have more complications. I'm happy with the result, same as you, and I think we should leave it alone. We did a final angio. Can we see it, please, without the wire? The flow is TIMI6 in the diagonal. And we have a right flow also in the LED.
Multiplied by 2.
We leave the distal LED as it is. I think it's better not to intervene. It's very distal. It's supplying only the apex.
Okay. So this is your final result. I think deserves a round of applause. That wasn't clear at the beginning. That it would come out so nice on the angiogram. I think it was a good demonstration of the use of tools of OCT and also ablation techniques. It clearly showed that, I mean, all of us in the room know how difficult it is to maneuver such a heavily calcified vessel, including a bifurcation with a small size side branch. They are even more difficult. So congratulations again, that was a great case. We leave you there to finish the procedure and get the patient done and off the table. And we'll have a little discussion here at the end as well. If you have any final comments, please, Hussein, or any summary, we're all ear.
Thank you. It's an honor to be with you, and hope to see you again next year.
Thank you.
Thank you. Thanks to Riyad.
Thank you. Have a good day.
So we have touched on two interesting topics, and that was the OCT and the tools. And it's really a great pleasure in the flow of this session. We'll now have two keynote lectures, really. One, Giulio, on OCT. I've seen it before, it's spectacular. It's all the newest things. And then Hussam Noor will talk about tools. And then at the end, we'll have time for questions and discussion. Giulio.
Okay, thank you very much. It was exactly the title, Actionable Imaging to Simplify Severe Calcified Lesion PCI. We realize also watching to the angio that the calcium is going in two different directions. Toward the lumen, we saw how much encroachment we had, and toward the media, the external part of the vessel. OCT is absolutely aligned with the detection of the calcification in both of the directions. Here you can see different images. This one with still some EL around. In the second one, the calcium was completely invaded the external part of the vessel with a larger lumen. In the third one, you have a calcified nodules that was ruptured. So the most important concept that we saw also in this case is calcium is not one thing. When you have a severe calcification, like in the case that we had or this one, you have a different type of calcium inside. Here you have a protruding smooth nodular calcification. Here you have some arc of the circumference, much bigger. This is much deeper. This is a little bit more superficial. Why is so important? Because if you are not preparing the lesion properly, and if you are leaving some block of calcification, some crunch of calcification inside, especially if it is a nodular calcification, you might end up with these results. No full apposition and no wide expansion. So it's extremely important to get this type of information. In addition, the measurements. Here you can see one case similar to one that we had today with a severe calcification before injecting. The final results that looks absolutely fine, and this is the same as interpreting by measurements, a more objective way, with in red highlight the under-expansion of the stent that was only 30% at this point. So very important to see and to get the measurements. This is the new generation. The new generation is fusing imaging with the measurements and with the super angio. You can pan, you can zoom, especially doing the stent implantation is going to be extremely useful. Here you can have the major two contribution of AI in this type of technology. One is detection of the calcification that you can see clearly in your angio co-registration in orange, and then you have the calculation of the arc of the circumference, and you get the measurements. The second one is to be able, and was partially used today, to show not only the lumen, but to show with this tiny line also the EEL when is visible. When there is a lot of calcification and cannot be seen, you cannot have these measurements expressed. This is the strategy to go step by step. Today we had a disrupted example of how we think that we should go with a very expensive technology, and instead a very normal 2.5 balloon was making a lot of crack. So we are building this strategy. But what is important is, first of all, imaging assessment. Today was not possible because the lumen was too tight. balloon or rotational atherectomy, open up the channel, and then try to get some idea about the calcium distribution, and of course, to select the tool. When it's uncrossable, we saw an example, rotational atherectomy or orbital, or eventually, for the lucky people, also laser. And depending upon if a superficial is a deep, you can select a different type of tools. And then, very important, to go to the post-PCI assessment. This is the strategy in steps. We use only 2 today, also because he had a limited renal function, and we wanted to eliminate the contrast. I was talking about this dynamic angiosync that is coming in this new type of AI-enhanced software, where you can magnify enormously your angio view, especially at the time of the stent implantation, putting side by side the co-registration and the angio, making the placement extremely precise. This is what we are doing today, going step by step. Once again, in angio, depending upon the projection, you have a different perception of the calcification. Here is doubtful. Here is becoming more clear in this view before injecting. Here is becoming much clearer in spider view. This is not what we are going to get in OCT. You have angio co-registration that is a crucial part of the imaging, and you have identified exactly where is the calcium display in orange, and for any type of measurements, any type of section, you can see that when there is a calcium, it's telling you the arc, and it's telling you also the thickness. This is the next step, is in the same acquisition, you have not only display where is the calcium, but you can get the measurements. Which type of measurements? When is visible, likewise in this cross-section at this point, you have not only the lumen display and the area, but you have also the EEL automatically display. When instead is no visible, going to the different part, when there is the calcium, is showing only the measurements of the calcification. That is another example I was possibly feeling about this case. Here you can see an example of a deep crack, likewise we had today. This was not lithotripsy, this was not cutting balloon, it was a simple non-compliant balloon. The message is we are still learning about how to combine the best device with the calcification morphology. Very important in this technology, you can also compare the different step of your procedure. Here you can see the lumen in a severe calcified lesion, likewise I was showing, from the proximal to the distal. And when you prepare the lesion, after the preparation, you can confront the two and see how much you gain in terms of lumen, and if there is also some point that is still underexpanded in terms also of lesion preparation. In this case, you are coming back with your angio co-registration, and you are going to be more aggressive selecting different tools. Likewise, in this case, shockwave. This is the final results. Again, you have angio co-registration, and you can see the automatic detection of the profile, and if you have malposition, you can also see the malposition, and you have the final measurements that we haven't explored today of the expansion and the MSA. Very, very important. We saw today when you are dealing with, when you are facing with a severe calcification, it's not easy to bring down any type of device. It was difficult also with the balloon. It was impossible. You can imagine with an imaging catheter. But the imaging catheter are going to ameliorate significantly. This is the case I was showing with different passages obtained by some new generation catheter that is a much better profile with a shorter nose cone, and that is going to be very helpful when you are dealing with the calcification. Some tricks for everybody. Here you can see a heavy calcified vessel, difficult to bring down the wire using the microcatheter, and then you need to bring down an imaging catheter. This is what should not be done. Doctor, the OCT catheter, because it's pushing back the guiding wire. In this case, I disengage. In this case, it's much better to keep pushing the OCT catheter while you are keeping in track, you are pulling back gently your wire, and you are making gently the progression of the catheter. And this is what, in this bandit situation with a severe calcification, it was done and it was possible. So just to summarize the key messages, calcified lesions are significantly increasing. Why? Age, diabetes, CKD. Calcified lesion is one of the best settings to apply OCT, gain more. We got an example today. Technically, calcified lesions are more demanding but more rewarding in terms of final results. Pre-procedural assessment is crucial to plan the procedure. Today, nothing was crossing. We didn't have the baseline, but we exchanged with the post-lesion preparation to see if we can go with the stent, and AI application can simplify the procedure. Thank you.
That was fantastic. And now to be followed by an equally fantastic talk by Hussam Noor about the tools in the cath lab. Hussam.
Hello again. It's very difficult to follow my talk after Julius. Just an amazing talk about the utility and how we do things. I just want to remind, while I'm sitting in here, I thought of something, and where did we come today? When I was a fellow in interventional cardiology, at one time I was thinking about with myself is, what is this? Wire, balloon, and stent. And look where we are today, how much details we're putting into the calcium, how much imaging has helped us, how much artificial intelligence. And over the 20 years, this has progressed significantly on how we really treat our patients. So my task today is to share with you some of the tools and on approaching calcified lesions from preparation to optimization. So, and this goes again, what is the impact in calcium on your PCI outcome? We all know that when you do PCI on a heavily calcified vessels, the outcomes are not as good as when you do it in a very like hyperplagic lesion or hypoechoic lesions. And this data shows you first and second generation DAS, and the outcomes are completely different. So we have seen in the case, we're used to assessing calcium just looking angiographically, but also in angiographically you can tell whether it's mild or moderate or severe. The case that Dr. Hussein Al-Umri showed us earlier definitely was severe calcium because you can see the calcium even on the still images. Now, I think I want to bring up to your attention the issue of vessel compliance, and I think we need to have a mindset that what we're trying to do with all these tools is to change the vessel compliance, to make this vessel more compliant. And calcific lesions, they are actually 4 to 5 times less compliant than other cellular plaques that we have in our in treatment of coronary disease. Dr. Giulio showed very eloquently the imaging that we use, and we have in common practice we have the IVUS and OCT, and both of them have their limitations, but there are some advantages with OCT in which it can give you the thickness, in which the IVUS cannot give you all the time the thickness of the calcium. Now, going back to the issue of the vascular compliance, what happens with the calcium? When you have the calcium, as we have seen in the case, it impairs and prevents the delivery of your material, your balloons, your atherectomy device, or even your stent. And then you require using some devices to make the vessel better compliant. And then if they have still calcium there, even when you try to push the stent, all of us had this problem in which you damage the stent or the stent comes off the balloon. And this is the worst thing that could happen to you is you say, well, I'm going to deliver the stent, but the stent did not get a good expansion. And what we're trying to do is to, once we have a better compliance of the vessel, this would turn into a clinical outcome, which is you decrease your MACE and you decrease your TLF. So the utility of intravascular imaging, as we've seen elegantly in the case and with Dr. Julia's presentation, you need to look at the calcium morphology. Is it concentric? Is it eccentric? Is it nodular? And not uncommonly, the calcium is all of a mixed type. And that would be married to looking into how severe is this calcium? What is the arc of your calcium? What is the length? What is the thickness? Are you dealing with a nodule? And when you put these two things together, you will come in to say, well, let me think, what is the best way I'm going to approach this calcified lesion? Now, the challenges in DS performance in these calcified lesions, so you may end up having an incomplete stent apposition. You may end up having stent under expansion, or when you try to crank it up, you could also have edge dissections. And even in the case that we had earlier, we're looking into these things with imaging to make sure that we have a calcified lesion, that we avoid all of these issues to have a better outcome for our patient. The other thing, the other side of the spectrum is what happens with the calcified lesions if you don't prepare properly, and then you always have a risk of complication, and the worst complication that we all fear of is the perforation, and this is an example of what could happen in calcified lesions. So what is an ideal attribute of calcium modification? You have a calcified vessel, you balloon it, ideally you want to restore the vascular compliance. And when you restore that, you decrease the procedure complication, and then when you marry these two together, you maximize the compliance and you minimize the complication, you'll have the best outcome for your patients. So in stent under expansion and asymmetry, what is your approach defining acceptable result? And that was discussed earlier. I'm just going to re-emphasize on the point. Are we really looking into the absolute MSA, or are we looking into the relative MSA? And are we looking into the circular area? Or does that really make a difference, or the asymmetry? So I think in that is you have to combine all of these things together for your own. Every single patient is different. And also when you look into the calcium, you have to think about what are the risks of your complications. And that's what we ask about this case. What pattern of calcium are you dealing with? Is it an eccentric calcium? Is it, and if you go with an eccentric calcium, one-to-one balloon, non-compliant, are you at risk of perforation at the shoulder areas? Are you dealing with a nodular calcium? And also the nodular calcium has different subtypes of it, but this is not the scope of this discussion. And again, when you have nodular calcium, when you take one-to-one non-compliant balloon, are you at the risk of a perforation? That's one. The other thing is also think about the lesion location and the patient factors. So, for example, in the case that we had the LAD diagonal, if you looked, the diagonal itself was heavily calcified, and I'm very happy that we all have a consensus to leave that alone, because my feeling is that diagonal was heavily calcified, and if we went ahead and did a two-stent strategy, we would not have enough expansion, then we'll end up with a more MACE and target vessel failure than having good. And I think that's a concept that we have to share, lesion location and the patient factors as well. So what are the treatment options for calcified lesion? I think I categorize them into two different categories. Is atherectomy devices, rotational atherectomy, as we've seen in this case, orbital atherectomy, laser atherectomy versus balloon-based technologies. We're all used to the balloon-based technology, but there are some limitations in the balloon-based therapy. Now, when you have a calcium, and this is an eccentric calcium, and you put a balloon in there, and you start to inflating to get the lumen, you're always at the risk of having a shoulder perforation. And this is where imaging helps you to minimize that risk. And that I don't like to reemphasize anymore what Dr. Julie has said. Imaging helps you to minimize your risk. And when you have a nodular as well, it's the same thing. So you put all of these things together when you want to go. It's not like what we used to be in the past, wire, balloon, and stent. No, you need to incorporate all of these things to minimize the risk of your patient. So I think and limit the use of non-compliant balloon in concentric calcium. And again, it was exemplified in this case with concentric calcium. They used a non-compliant balloon, high pressure, and it cracked it, and they dissipated the forces in a radial fashion. It wasn't going one way or another, so the risk of perforation is less. And then versus if you had an eccentric calcium, you go very high pressure, non-compliant balloon, there's always a risk that you may end up with a perforation. So, and what is your treatment goal? It's the area and it's not the concentricity. So if you have achieved a good area, regardless of asymmetry, that would be your goal, and that is determined by the MSA or relative MSA, and how much expansion do you have compared to the distal vessel and the proximal vessel. So back again to the treatment options. In one of the advantages which we haven't used in this case is the orbital atherectomy. So think about the calcium, think about you have a platform full of stones and you have like a mountain of calcium, nodular or eccentric. So what all these devices would do for you, think about the concept of shave and shock. You shave the mountain peak and shock the base. An orbital atherectomy is one device that you can actually shave it from the top, and also by the pulsatile forces could crack the rocks at the bottom, in which you would have better compliance with your blood vessel. So what are my take-home messages? There is severe calcification leads to stent under expansion, higher TVF rates, and complications, specifically perforations. Device choice is dependent on the OCT-IVUS identified calcium morphology, and of course, emphasizing on the point that calcium fracture or nodular debulking should be identified prior to DAS deployment. And thank you very much for your attention.
Excellent, thank you. Join us here. I think we've got time for one, maybe two questions, and then a wrap-up. There is a question on the floor.
To be honest with you, in my practice, I will use IVUS catheter and it will help me and will deliver most of information I will need for this particular case. I have OCT indication for mechanism of failure of in-stent stenosis or unclear lesion, but for calcific lesion, I'm not sure.
Julia.
Well, I think it's one of the strongest indication that we have also from the trials. And I think that the difference is made by the thickness, because with IVUS, when you have a thick calcium, you are shadowing, and you don't know how much is thick. And that is making the difference. In OCT, you can penetrate the calcium, and you can detect, and we saw during the live case very clearly, and you might add this to the other parameter. That is one of the most critical to make asymmetric or symmetric expansion, lumen big or lumen smaller. So I recommend this as one of the most significant indication for OCT.
Clear statement. Mohammed, I've got one question I throw at you. We haven't discussed that before, but the one thing that we haven't discussed at all throughout the case is the stent platform. How important is the stent platform that is used if you have long calcified lesions like that? Can we just throw in any from the shelf, or, do we rely on particular features?
Yeah, I think most of the cath lab people, the operator, they get used to some sort of a stent. And I think when you think about the stent, one of the major problems, especially with those, you don't want longitudinal compression. That's one of the major problems, and you know which platform it might give you this. But I think just the OCT, we have a good experience in the area since we start the absorb, and we trust in the OCT. And one of the good news for our people here that we're going to join a big registry for the first time, and we will participate from Saudi with 500 patients.
Excellent, Yunus, and you said that yesterday. I think that's great. Time to wrap up. I think what we've seen is a challenging case with a long lesion and a bifurcation. Lots of challenges in there. We learned about the use of debulking, use of OCT, and the provisional approach for the stents. We had great lectures, and I can see there's one more question, but it's definitely the last one.
Very, very
short.
short.
We need to move on.
One of the big hurdles we have to use in using OCT in the third world, in the poor world, is cost.
Yeah.
And I went to learn it in India with Nishit Chandra, where in India, the probes are actually reused very safely, very effectively, because there's no other choice. Otherwise, there will be no OCT. So I'm really calling on all of us to do something to be able to cut the cost for the third world, like, you know, maybe use older generation probes or something. Okay. We're desperate, you know, but we're millions. We're actually hundreds of millions, and we have no access.
We hear this message, and we did learn a lot about the use, and we made a point that it is a really class 1 indication for a particular situation. And you know, I hope we can do something about this. And normally, widespread use should actually bring down the cost. And with 7 seconds to go, I say thank you very much. This was a sponsored session by Abbott Vascular. I think it was very educative. I think we've seen a great case. Thank you to the panel, the speakers, and thanks for the great interaction and discussion.